In the last section, I explained about vertebrobasilar insufficiency. At this time, we will talk about central paroxysmal positional vertigo. Unlike vertebrobasilar insufficiency, nystagmus is observed in alternating directions in this disease. Although this disease is originally caused by the brain, it is not yet fully recognized by many medical institutions and is often diagnosed and treated as benign paroxysmal positional vertigo caused by the ears. Therefore, in order to understand this disease, I would like to explain the broad meaning of paroxysmal positional vertigo first. The concept of paroxysmal positional vertigo can be divided into three categories. 1. Benign paroxysmal positional vertigo (BPPV). 2. Central paroxysmal positional vertigo (CPPV). Again, this disorder is not well recognized by general physicians as well as otolaryngologists. 3. Malignant paroxysmal positional vertigo (MPPV). This disease is a vertigo that can be fatal. As for central paroxysmal positional vertigo, the late German professor of neurology, Dr. Kornhuber, proposed the existence of a pseudotype, or pseudo-benign paroxysmal positional vertigo. He suggested that this disease, also called central paroxysmal positional vertigo, was more common than benign paroxysmal positional vertigo. The cause is poor circulation in the vertebrobasilar artery. The nystagmus is alternating in direction and the symptoms are very similar to those of benign paroxysmal positional vertigo, so it is difficult to distinguish between the two. Cervical spine X-rays and cervical MRA are the key to diagnosis. These are explained in more details with clinical cases later. For more information, please refer to my book, Escape from Assumed Vertigo Treatment. Vertigo is not always from the inner ear, published by Shinkuigaku Shupansha in 2015 for doctors, and my book, Vertigo or Dizziness That Does Not Get Better Will Be Cured. Vertigo is not always from the ear, published by Sakura Shah in 2018 for the general public. At the forefront of otorhinolaryngology, Tabuchi et al. Reported that central paroxysmal positional vertigo was the most common among the three types of paroxysmal positional vertigo listed above. I heard from an influential doctor that the late German neurology professor Kornhuber had the following episode. Whenever a doctor came to his office wanting to study abroad, the professor used to ask him the following question. What percentage of all vertigo is benign paroxysmal positional vertigo at your institution? If a doctor answered, it is very high, about 60% at my institution, the professor used to say, then please go back to your country after sightseeing in Germany, and if another doctor replied, it is about 20 to 30%, the professor would say, well then, please study here. The recent trend is that the name of benign paroxysmal positional vertigo is easily given without nystagmus findings based on medical history alone, and I believe that this may be the reason why this name of disease is too common. I want to inform you that the source of central paroxysmal positional vertigo is a famous neurology professor in Germany. Then let's talk about dangerous vertigo and/or central vertigo and how to recognize it. Most people, including doctors, think that vertigo is only a common symptom, and that dangerous vertigo is rarely. Nevertheless, if you think that way, an unexpected pitfall awaits you. When I was an otolaryngologist, dangerous vertigo was infrequent. However, since I started seeing vertigo patients in the Department of Internal Medicine, where there are many middle-aged and elderly people, I came to encounter dangerous vertigo and/or central vertigo from time to time when I examined brain MRI, MRA, and cervical MRA, even though the vertigo seemed to be from the ears at a glance. Here, I would like to talk about the social background of middle-aged and elderly people from the medical point of view. Compared to the past, more middle-aged and elderly people today have risk factors such as hypertension, diabetes, dyslipidemia also called hyperlipidemia, visceral obesity, atrial fibrillation, and smoking, which have increased the risk of developing vertigo from the brain based on vascular lesions caused by arteriosclerosis. Nowadays, the probability of diabetes among middle-aged and elderly people is 1 in 4, including those with pre-diabetes. In addition, about 40% of people over the age of 70 have pre-diabetes. Diabetes is associated with rapid progression of atherosclerosis, and blood glucose levels and platelet agglutination ability are positively correlated. In other words, when glucose level is high, platelets tend to be activated accordingly, blood flow becomes stagnant, blood circulation is poor, and in some cases, blood clots thrombus are more likely to occur, resulting in obstruction of the arteries, making it easy for cerebral infarction and myocardial infarction to occur. Vertigo in the elderly requires attention to cerebrovascular disease. Professor Brandt, a world-renowned neurologist in Germany, is of the opinion that 70 to 90% of vertigo diagnosed as vestibular neuritis is a small stroke. In the past, vertigo was often diagnosed as Meniere's disease, although this has been replaced recently by benign paroxysmal positional vertigo. Many people think of vertigo as being caused by the inner ear, but there are times when they fall into unexpected pitfalls. This was my experience when I was at Yokosuka Kyosei Hospital. I remember one family member telling me, "My grandfather got vertigo, so we requested a doctor nearby to do a home visit, but the doctor diagnosed him with Meniere's disease and returned to the clinic. Although my grandfather died of a stroke 3 days later." This kind of thing can happen rarely when doctors stick to the inner ear as the cause of vertigo. My aunt, who was 90 years old at the time and lived in the countryside in the northern part of Tochigi Prefecture, also suffered from vertigo, and her family requested a nearby doctor to make a home visit. When the doctor left, he said, "It's probably vertigo from the brain, so please be careful of cerebral infarction in the future." I was impressed by the fact that even in the urban, the diagnosis of vertigo in the elderly tends to be of inner ear origin, but there is an excellent doctor in the countryside of Tochigi Prefecture. So what kind of patients get dangerous and/or central vertigo? 1. Middle-aged and elderly patients with risk factors. For example, patients with both hypertension and diabetes are said to be predisposed to cerebrovascular diseases, so they need to pay attention to cerebrovascular diseases such as cerebral hemorrhage and stroke. Dyslipidemia, visceral obesity, atrial fibrillation, and smoking are also risk factors for dangerous and/or central vertigo. 2. Here is typical situation that you may encounter. For the concrete, if a middle-aged or elderly person with risk factors of hypertension and diabetes develops sudden onset vertigo at dawn, accompanied by occipital pain, vomiting, and stagger, he or she should think of infarction or hemorrhage of the cerebellum or brainstem, and go to the hospital by ambulance, where he or she should undergo MR imaging. Brain CT alone is insufficient to detect fresh infarcts and small lesions. However, in the case of nighttime, it may not be possible to take MR, so in such a case, it is recommended to get MR back at a later date as soon as possible. 3. Diabetic patients with poorly controlled hyperglycemia should be considered for central vertigo due to vascular lesions such as narrowing, occlusion, or aneurysm of arteries from atherosclerosis, not to mention vertigo or even mild dizziness of lightheadedness or unsteadiness. 4. Vertigo in collagen disease patients is often based on vasculitis, so central vertigo should still be considered. 5. Patients with blood disorders, especially true polycythemia vera and idiopathic thrombocythemia, have platelets that can reach 900,000 to 1.5 million. Normal platelet count is around 200,000, so they are prone to thrombus formation, which means that central vertigo should be considered. Next, I will talk about how to recognize dangerous vertigo by other symptoms. There are 3 important symptoms to pay attention to, namely headache, numbness, and double vision. The most important headache is occipital pain. In case of vertigo with occipital pain, a lesion in the brainstem or cerebellum should be suspected. When vertigo is accompanied by numbness, especially in half of the body including the face, a thalamic lesion is considered. In addition, when there is numbness in one side of the hand and lip, hand-mouth syndrome is considered. The responsible lesion is the thalamus or midbrain. Dangerous vertigo is suspected when the vertigo is accompanied by double vision, strong imbalance on standing and dysarthria. In addition, when there is vertigo and blackouts in front of the eyes, a lesion in the occipital lobe of the brain is suspected. Furthermore, when vertigo is associated with frequent vomiting, dangerous vertigo is also considered. Vertigo with loss of consciousness and paralysis can be regarded as dangerous vertigo. A relatively high probability of encountering dangerous vertigo is Wallenberg syndrome. Symptoms include gait disturbances such as tangled legs and wide-based gait or out-toeing, difficulty swallowing food, and thermosensory and pain disturbances in the affected face, contralateral trunk, upper and lower extremities. Another important factor is pain in the lower neck. This can also be caused by stiffness in the neck and shoulders, or circulatory disturbance in the vertebral artery. However, it is important to note that sudden pain from behind the ear called the posterior auricular region to the back of the head is suspicious of vertebral artery dissection. Medical book describes this occipital headache as a severe pain, although it can also be a mild pain, so caution is required. A male patient in his 60s, whom I was treating for vertigo and hypertension, was transported to our hospital by ambulance due to severe vertigo one day. When I was called to the outpatient clinic to see the patient, I asked, "Do you have a headache?" He replied, "Well, I have a slight pain from my neck to the back of my head." At that time, the vertigo was alleviated with anti-vertigo medication and I sent him home, though brain MRI and MRA revealed both dissecting vertebral artery aneurysms later. After consultation with the neurosurgeon, the dissecting vertebral artery aneurysms were followed up conservatively. However, several years later, the patient had a stroke in the carotid artery region. Even if the patient has only vertigo and no other neurological symptoms, it was reported that the probability of having a stroke after 3 years of follow-up was 12%. Anyway, vertigo in middle-aged and elderly patients should be cautious. In the next sections, I will explain with concrete cases of vertigo.